Hello, and welcome to an evidence-based approach to assessing COPD, a video produced in conjunction with the UC Davis School of Medicine. In this video, we'll provide a quick overview of the evidence-based physical exam. We'll discuss an evidence-based approach to physical diagnosis and assessment of chronic obstructive pulmonary disease. And finally, we'll show a video of a UC Davis Master Clinical Educator demonstrating high-yield physical exam maneuvers that every UC Davis grad should know and the evidence behind them. Hand washing before and after each physical exam has been well studied and shown to reduce morbidity and mortality in the hospital and the clinical setting. We were all taught the four basic components of a complete pulmonary exam: inspection, palpation, percussion, and auscultation. And while these provide the foundation of a complete pulmonary physical exam, this video is going to take a slightly different approach. An evidence-based approach to the physical exam begins with a diagnostic question. For example, does this person have chronic anemia? To answer the question, you first estimate a pretest probability, which is essentially your best guess as to how likely you think this patient is to have the pathology in question, based on aspects of their history, presenting symptoms, etc. It's generally expressed as a percentage. Using this as your starting point, you choose an evidence-based physical exam maneuver, which, depending on whether the test is positive or negative, will feed back on your original hypothesis, giving you a new post-test probability, as demonstrated in this figure. For example, if you don't think that your patient is anemic, giving them a pretest probability of 20%, but then you discover conjunctival pallor on exam, that really changes your thinking, giving you a much higher post-test probability. How much a given physical exam maneuver changes your pretest probability depends on the sensitivity and specificity of the test, which in this case is expressed as a function called the likelihood ratio. You can see in the figure how a positive or negative likelihood ratio can affect your pretest probability either a great deal, for example if you have a positive likelihood ratio of 10 or more, or barely at all, for example a likelihood ratio close to 1. Let's look at how this approach works when assessing the patient who may have COPD. To begin, we estimate our pretest probability, which is our best guess as to whether or not we think this patient has COPD and how sure we are about that expressed as a percent. Now this is based on aspects of the patient's history, such as their age and, as you may have guessed, their smoking history is of paramount importance here. Now I wanted to mention the results of a meta-analysis that was published in JAMA in 1995 that suggested that if you have more than 40 pack years in your smoking history, then you are 24 times more likely to have COPD than somebody who smoked for less than 20 pack years. Now below you can see several physical exam findings that are associated with COPD, along with their positive and negative likelihood ratios, which are a result of the pooling of several studies that have been done over the years. We've highlighted a few of these that we found to be particularly useful in ruling in or ruling out COPD. For example, let's look at maximum laryngeal height less than 4 centimeters, which has a positive likelihood ratio of 3.6 and a negative likelihood ratio of 0.7. Now, maximum laryngeal height less than 4 centimeters is a sign of more advanced stage COPD. So its positive likelihood ratio is fairly good, meaning that if you discover this sign, that it becomes quite a bit more likely that this patient has COPD. However, its negative likelihood ratio of 0.7 is not very significant, meaning that if the sign is not present, it doesn't necessarily rule out COPD. They may just have a milder form, or they may have other aspects of their anatomy that prevent you from noticing this. Let's learn a little bit more about how to assess the laryngeal height. So how do you measure the laryngeal height anyway? Well, simply it's the distance between the little divot in a patient's thyroid cartilage and the nadir in a patient's suprasternal notch. And you want to have the patient hold their neck in a little bit of extension while you measure this so you can get a maximum height. And the thought here is that in a patient with COPD who has chronically hyperinflated lungs and flattened diaphragms, that extra negative space ends up pulling down on the entire respiratory tree, including the trachea and up at the top the thyroid cartilage. So a distance there of less than 4 centimeters is relatively predictive of COPD if your pretest probability is high enough. Here's UC Davis Master Clinical Educator, Dr. Mark Henderson, to explain.
Something else that happens with emphysema is there's air trapping, if you will, and so there's an expansion of the chest. There's barrel chest and there's expansion of the AP diameter. What happens when that occurs is the clavicles, in some sense, are pulled up. And so one way to measure that is the distance between the suprasternal notch and the top of the thyroid cartilage. So it's this distance here, if you can see. So suprasternal notch and the thyroid cartilage. If this distance becomes less than 4 centimeters, that's suggestive of emphysema. So, and we'll measure the distance in this patient. Let's see again, top of the thyroid cartilage to the sternal notch is about 8 centimeters. Between 7 and 8 centimeters. My finger's on the top of the thyroid cartilage, so something like 7 or 8 centimeters. So that's normal. Again, less than 4 centimeters would be suggestive of air trapping or emphysema.
Another maneuver that's been shown to be useful in either ruling in or ruling out COPD is the presence of something called Hoover's sign, which has a positive likelihood ratio of 4.2 and a negative likelihood ratio of 0.5. A positive Hoover's sign is when you observe or palpate the inward motion of the bottom part of the rib cage upon inspiration, as shown here. Two of the physical exam findings that have among the highest positive likelihood ratios, a subxiphoid point of maximum impulse and absence of cardiac dullness at the lower left sternal border, can be explained by looking at this chest x-ray. Note that in the hyperexpanded lung fields, the heart dangles in the midline like a pendulum over the flattened diaphragms. So that when you're palpating for the point of maximal impulse, you're going to find it oftentimes under the xiphoid process rather than the midclavicular line where you'd expect. Furthermore, when you're percussing over the left lower sternal border, rather than an area of relative dullness, which you would find typically over the heart, you'll find an area of resonance because the heart is displaced from its normal position. Again, Dr. Mark Henderson.
We don't teach percussion of the heart for cardiomegaly, although it is possible to use and has been used in the past. One of the signs of COPD with pulmonary hypertension tends to be that the axis of the heart shifts to the right. So the left ventricular apex will actually be pulled downward, inferiorly. So rather than having dullness to percussion in the left lower sternal border, the heart will move into the subxiphoid area. So you'll have absent dullness to percussion where the heart would normally be. So let me just percuss the heart here. This is lung, lung. That's heart. So this dullness here at the left lower sternal border would be absent, and might be moved down here into the subxiphoid area, which is normally tympanitic, right? Stomach. This sort of tympany, resonance, and then dullness. This area of dullness would move down into the subxiphoid area, where it's still resonant. So the heart again would be shifting into this part of the abdomen with a rightward axis, or air trapping and emphysema where the diaphragm is pulled down, stretches out the heart.
Here we see Dr. Henderson palpating for the PMI in the normal position in the midclavicular line. In a patient whom you suspect may have COPD, air trapping, if you do not feel the PMI in the normal position, palpate in the subxiphoid area or at the left lower sternal border. If you feel the PMI in one of those two places, that's further evidence that your patient may have a more severe form of COPD. When doing the auscultatory exam, It's useful to know that unforced wheeze, something that we oftentimes associate with obstructive lung disease, is actually not as sensitive or as specific as reduced breath sounds or an abnormal forced expiratory time in diagnosing COPD. Note that with a positive likelihood ratio of 3.2 and a negative likelihood ratio of 0.5, reduced breath sounds is actually more useful in diagnosing COPD than listening for a wheeze. Furthermore, if a patient has a forced expiratory time of less than 3 seconds, that has a positive likelihood ratio of 0.2, making it much less likely that a patient has clinically significant COPD. Finally, some of the more recent studies on COPD have used some of these combination rules to either rule in or rule out COPD. I find these to be particularly useful because they have very strong predictive value. For example, as a combination rule-out test, if a patient has smoked less than 30 pack years, has no reported wheezing, and no auscultated wheezing, then the positive likelihood ratio is 0.02, making it extremely unlikely that this patient has COPD, regardless of what your starting pretest probability is. Conversely, if your patient is over 45 years old, has a smoking history of greater than 40 pack years, and a maximum laryngeal height, like we discussed before, that's less than 4 centimeters, that's associated with a positive likelihood ratio of 58. Again, that's extremely predictive, and you do well to remember it in the clinic. So let's take a look a little further using McGee's evidence-based physical diagnosis calculator available online. So, from the drop-down menu, we select chronic obstructive lung disease, and we choose our pretest probability, based on how sure we are that this patient has underlying COPD to explain their symptoms. Now let's say we're pretty certain. Our pretest probability is 60%. And we look at one of the tests that we discussed earlier, maximum laryngeal height, less than 4 centimeters. Remember, that had a positive likelihood ratio of 3.6. So if we do nothing else and we do that physical exam maneuver and it's positive, then our post-test probability is over 80%. We go from 60% sure to more than 80% sure that this patient has underlying COPD. But remember, maximum laryngeal height was part of one of these combination tests. If our patient is over 45 years old, has more than 40 pack years smoking history, and has a max laryngeal height less than 4, then we are nearly 100% sure. Remember, that positive likelihood ratio is 58, so extremely powerful. Let's think about another one of our tests, wheezing. So unforced wheezing had a negative likelihood ratio of 0.8. Not much to write home about. It takes our pretest probability from 60 down to about 56%. It barely budges at all. But if you take that absence of wheezing in the context of a patient who doesn't report any wheezing in their day-to-day and has smoked less than 30 pack years, well, that positive likelihood ratio is 0.02. taking you from about 60% sure that this patient has COPD to almost 0% sure. So, these combination tests have a huge impact on your post-test probability in evaluating patients. Okay, so let's look at one more, Hoover's sign. We learned about this before, and it has a positive likelihood ratio of about 4.5, taking you from about 60% sure to about 85% sure. So again, that's significant. It has a negative likelihood ratio of 0.5, so if you don't see it, again, it reduces your pretest probability by about 18%. That's a significant amount, making this a high-yield physical exam maneuver to perform on a patient with suspected COPD. So in conclusion, let's review 4 take-home pearls from this video. The first is that a patient's smoking history is absolutely key for determining their pretest probability, with 40 and 20 pack years as cutoffs for many of the studies that have been used to back this up. Second, observation and palpation of things like Hoover's sign, maximum laryngeal height, etc. are just as useful as auscultation in assessing a patient for COPD. Third, while wheezing and barrel chested morphology are classically taught as features of COPD, they have surprisingly low sensitivity and specificity in the clinical trials that have compared them to other physical exam maneuvers. Finally, combination tests such as those discussed earlier are extremely useful in both ruling in and ruling out COPD.